So cultural competence is a very packed term. It means different things to different people and also to different people of different disciplines. This program sought to develop a module or an educational program in cultural competence specifically for public health professionals. We did not necessarily create anything new. We went to the literature to see what already existed. And there's a fair amount of information about cultural competence in the clinical world, for instance, in medicine and in nursing. There's a different approach to cultural competence in education as well as in social work. For our purposes today, we're focusing on cultural competence in the field of public health. And that said, if you look at this next slide, we picked a definition from the literature that we thought was most appropriate for public health professionals. It reads, cultural competence is the ability of an individual to understand and respect values, attitudes, beliefs, and mores that differ across cultures, and to consider and respond appropriately to these differences in planning, implementing, and evaluating health education and promotion programs and interventions. That's a lot all in one place, but it really speaks to individuals in public health first having an interest in learning about different cultures, the characteristics of people of different cultural groups, and then seeking to integrate that knowledge in the kinds of public health programs that we ultimately develop. So why do we need cultural competence? Well, in public health, unfortunately, there are a wide range of disparities, health disparities, by different cultural groups. So in this slide, as you can see, the different groups that we focus on are racial ethnic groups, including African Americans, Hispanic or Latinos, American Indians, Alaska Natives, Asian Americans, Native Hawaiians, and Pacific Islanders. All of those groups have been shown to have disparate health experiences in a wide range of areas, including infant mortality, cardiovascular disease, diabetes, HIV/AIDS, cancer, etc. Higher rates in those areas, and conversely, lower rates in the health prevention areas, for example, of immunizations and cancer screening. So these disparities certainly are of concern to public health, the field of public health and public health professionals. And one source of them has to do with disparities in care. So for instance, we've seen in the literature that minority, for example, racial and ethnic minority patients are less likely to receive referrals for screening tests. It's also been documented that minority patients are less likely to receive appropriate treatments as compared to other groups. And particularly Spanish-speaking patients have been shown to more likely have their comments ignored by medical professionals. Not necessarily intentionally, but that has been documented nonetheless. In fact, several years ago, the Institute of Medicine issued a report having to do specifically with discrimination in healthcare called Unequal Treatment. And in that body of work, the extent of disparities in healthcare and therefore health status in different groups has been made very clear. So this next slide shows just one of what could be many examples, concrete examples of disparities in health outcomes. What this graph, this bar chart depicts are infant mortality rates by maternal race and Hispanic ethnicity from 2006. And as you can see, the bars represent different racial ethnic groups. And what the data show are the number of deaths among infants younger than 1 year old per 1,000 live births. So as is very clear from this graphic, Black non-Hispanic mothers and American Indian Alaska Native mothers experience much higher rates of death among their infants than other racial ethnic groups. These data are from 2010, and yet unfortunately they're not new, they're not surprising. These are trends that have existed for quite some time, and that really require concentrated effort to try to redress. In some way, shape, or form, culture must come into play in dealing with a health disparity such as this. So why do we need cultural competence? Again, we have health disparities. We may also want to ensure that the kinds of interventions or programs that we put in place are effective, and effective across cultural groups. So one can consider that there are many influences around behavior, different factors that will have an impact on individuals' behaviors. What we list here in this slide are a range, not necessarily complete, but a range of the possible factors or influences, including universal factors. Those may be factors that apply to all people, regardless of cultural group. For example, living or housing conditions, regardless of the cultural group that different individuals may come from in certain environments that they live in, there may be factors that affect health universally to all of these groups. Then we'll identify that there may be factors that are more specific to members of the same cultural group. Then there may be individual factors, personal differences that have to be or should be taken into account. And then there might be a host of other influences on behaviors. Those might be socioeconomic factors, experience with poverty, etc. They may be structural factors, differences in power in different groups. They may have to do with policies, geographic residence, etc. For our purposes, we're going to focus, of course, on the cultural factors. And another reason why we might do that is because culture has been shown to be a key factor in influencing the way people even come to think about health and illness. And they may think, depending on the cultural group that individuals come from, they may think that different behaviors either foster better health or impede health, and members of different groups may think about that in different ways. So what does it mean to be a culturally competent public health professional? This next slide lists 6 categories or approaches to trying to work toward improved cultural competence. The first 3 have more to do with how we interact and conduct ourselves with the populations of interest, the groups, cultural groups, for example, that we seek to serve and to work toward improved health. So, for example, these points speak to incorporating strategies to improved interactions between ourselves and members of diverse cultural groups. It speaks to considering the role of culture, social and behavioral factors in individuals' accessibility of the different kinds of public health services that we develop and make available, how available they actually are to target groups, how accessible they are. In addition, it also speaks to the diverse needs that not only members within a group may have around taking steps to improve their health, but how our approaches with different groups may have to be more customized. The last 3 factors have more to do with how we conduct ourselves as members of the field of public health in trying to advocate for increased recognition and integration of cultural competence at this disciplinary or professional level. So for instance, our ability or improved ability to explain the differences between cultural groups will help to advocate for increased cultural competence at a professional level. Our ability to describe the need for more diverse public health workforce so that the people providing services are actually ideally more similar to the groups that we seek to serve. And our ability as professionals to assess the cultural competence or lack thereof of different organizations. That too would go far or further to improving cultural competence in the kind of work we do. So how do we start to become more culturally competent in the work we do? This slide depicts a funnel with 3 key factors in it. What they represent are attitudes, knowledge, and skills that we bring to the work we do in public health. And we'll consider each one in turn. In terms of attitudes, what we seek to do is not change our attitudes, but achieve some kind of a shift in that we integrate an understanding and an appreciation for different perspectives. The way we describe it is that we would want our work in public health to include a desire to become culturally competent. And what do we mean by that? What we mean is that cultural desire would include a genuine passion and commitment to be open and flexible with others, a respect for differences, yet a commitment to build upon similarities, a willingness to learn from clients and others as cultural informants, and a sense of humility. That's not really something that can be taught. That's something that one would hope, one might assume, that in having chosen to conduct our work in public health, that would be viewed with open arms, that would be viewed as something of interest and critical to working with members of different groups. The sense of a shared goal for better health is one way that I like to think about it. And in achieving that goal of better health, we would prefer to take a collaborative approach and take into consideration the thoughts that other people have about what might be the best way to achieve the better health, and not necessarily assume that we, quote, know it all. Another piece of the attitude shift would be some kind of recognition, if not consideration, for the historical impact of racism and discrimination on health and health care. Since in this context of cultural competence, we're talking about racial ethnic groups, racial ethnic minorities, it seems to me that it would be impossible to be fully engaged with understanding the perspectives of members of other groups without taking into account the fact that there is a clear history, unfortunately, in this country of racial discrimination when it has come to the health of peoples of different groups. And we probably don't have to look very far. So for instance, in the work that I do, it's very clear that around family planning and reproductive health, it's almost impossible not to take into account the fact that women of color have suffered not too long ago abuses in that regard. For example, sterilization abuse. So the next element of our work toward becoming more culturally competent is to consider our knowledge and skills in the kind of work we do. 2 elements of that have to do with becoming familiar with cultural factors and increasing our understanding of how these factors affect behaviors. So to go back to the first point, becoming familiar with cultural factors is a really tall order. That involves considering differences in individuals on the basis of their racial background, their gender, their sexual orientation, religion, traditions, language, customs, values, communication styles, different kinds of family structure, the way in which holidays and other events might be celebrated, the importance or lack thereof of music and dance in the different cultural groups. It is indeed culture, and there's no definitive way to teach this. Once again, it's about the efforts that we make individually in our work in public health, as well as organizationally in the commitment that different institutions that strive to provide public health services incorporate increased knowledge about the differences that cultural groups have. The other piece to that is taking that information that we continue to learn about different cultural groups and further explore how these different factors may then affect individuals' health-related behaviors. So for instance, if certain groups are more involved in traditional healing practices, self-medication, complementary and alternative medicine, for example, there would certainly be a argument to be made for learning more about those practices so that we can determine on the public health side whether they are helpful in terms of improving the health and well-being of individuals, if they are harmful, and then in what way we might go about trying to influence changes in those behaviors. So having just said that part of increasing our knowledge and skills is learning more about cultural groups, behaviors, and how they influence health, that might lead certain folks to worry that some textbook approach to learning about different cultural groups, practices, and beliefs and behaviors might provide us with a textbook approach to dealing or interacting with individuals of different cultural groups. The fear that this would lead to generalizations or stereotypical thoughts about different groups, and that is a real concern. This slide, which we call Are These Stereotypes or Cultural Patterns, really speaks to that. And if you look closely at it, we have two columns here that pretty much might be thought to generalize differences between groups. On the one side, you have sort of Western-style belief systems listed, and then on the other column, you have non-Western belief systems. And they're broken down by core beliefs, health-seeking, cultural values, communication styles, and family dynamics. One of our concerns is that lists like these might indeed lead folks to consider them as definitive descriptors of cultural groups that apply to everyone in the group. But on the more positive or optimistic side, we can at least use this kind of a schema, if you will, in terms of maybe that it represents a continuum of factors or characteristics of a group. What you see in each of the columns might be the extremes of that spectrum or continuum, and that somewhere between those two ends might be where we, as public health professionals, when we engage with individuals from different groups, we might seek to maybe better understand where individuals fall within that continuum. So to provide a few definitions as a framework for going forward along these lines, we tend to think of generalizations as often used to summarize cultural beliefs or practices that point to common trends. Oftentimes it's undeniable that there are common trends among groups, but that's at the group level. The concern and what we want to be careful about is that leading to stereotypes, in which case we tend to think of that as inferring that a person or group fits a particular generalization without regard for the fact that there may be differences at the individual level. So we can use these categorical descriptions to allow us, sort of as a starting place, to allow us to think about the different elements that we should consider when we conduct ourselves or work collaboratively with members of different cultural groups, but always keeping in mind that this is just the background, and that in our interactions with individuals, we want to really situate ourselves around the individual's characteristics and not automatically assume or categorize individuals as fitting definitively into one end of this spectrum or the other. So the other point about increasing our knowledge or skills in an attempt to become more culturally competent, what we also want to focus on is how we increase our understanding of cultural factors as they relate to communicating about health, because ultimately that is what we do. We try to communicate about health, whether it's in development of different programs and interventions. They might be written materials, they may be multimedia materials, they may be one-on-one engagement with members of a community, but whatever shape or form or a medium that we use to engage with communities around health, we are trying to communicate a message around improved health. And in doing so, there are a few key factors that you'd want to keep in mind and make efforts to become more knowledgeable and skillful around. For instance, that the fact that there may be differences in communication style from more individualistic approaches to more collectivist approaches or perspectives. Certain groups may actually be more welcoming of approaches that we undertake that involve large groups, that involve interaction, and that have more of a collective approach to them. On the other hand, there may be other groups that are more responsive to individualized messages or modes of communication. Again, these are the kinds of things that in our work with other groups, in collaboration with other groups, that we would seek to identify which of these approaches, or maybe something in between the two, is most appropriate. Another factor to consider might be differences in family structure and values, because public health is a more population-based approach to addressing health issues. Even if we're interested in individuals within particular settings, individuals are members of larger structures, families, communities, extended families, etc. And those structures may differ by cultural group and may play an important role in how we try to communicate messages about improved health. Finally, social norms, which go beyond the family and to the larger societal group, in this case different cultural groups, may play a role in the ways in which we communicate about public health messages. So if we consider that becoming more culturally competent in our work involves this shift in attitudes and this increase in our knowledge and skills, there can be different approaches that we might take to assessing whether we have indeed achieved or are on our path to becoming more culturally competent. One approach to that is a self-assessment. We have developed, after considering the literature, after looking at the other kinds of tools that are out there, we have developed a self-assessment tool that is more specific to public health. And it's certainly a work in progress, and we hope to continue to improve it over time. But the self-assessment comes from the perspective that individuals looking to become professionals in public health may want to start with reflecting on their own knowledge, attitudes, and abilities to engage with and work with other groups. So this self-assessment tool, or survey, if you will, that we've developed collects data for ourselves around different issues. For instance, we ask ourselves in this assessment, how do I feel about race, gender, sexual orientation, religion, etc.? How do I interact with people different from me? How well do I know the cultural background? For example, prevailing beliefs, customs, norms, values, religions, philosophies of community members in the area in which I seek to work. Do I know how community members define health, illness, and major health concepts in my service area? It is by reflecting on those issues and those kinds of questions that we at least can establish a baseline for what we either know or don't know, or how we perceive different groups. What we recommend is that we all engage in this kind of a self-assessment, this reflection of our attitudes and knowledge of different cultural groups when we begin to work with different groups. And in this way, we have a concrete way of determining what it is we do and don't know, and where we need to do additional work in order to improve our knowledge and skills. So in addition to an individual assessment, in order that we as individual public health professionals can get a better handle on our attitudes as well as our knowledge and skills, working with other groups, other cultural groups, we would also suggest that it's important that we assess the cultural competence of organizations that we work within or that we work with. As such, once again, we consulted with the literature in what kinds of assessment tools currently or previously have been developed to do such kinds of organizational assessment. Once again, modifying previous work that currently existed, we tried to come up with an organizational assessment tool that speaks more explicitly to the work of organizations engaged in public health. As such, this slide summarizes the kinds of data that we would want to collect in the settings in which we're working that try to gauge whatever level of cultural competence the organizations themselves have. So for example, the questions in the organizational assessment might include, is cultural competence a part of the organization's mission, vision, values, and policies? Is it explicitly stated to try to become more competent in working with diverse populations? Do we consider culture in our assessments and service plans, the different programs we develop? Do we have linkages with diverse communities and organizations? Might a public health organization have developed very effective public health programs and interventions, but maybe have limited them to certain groups? And might it be possible to adapt and expand them to diverse populations? Do we, the public health organization, utilize community consultants, what are also referred to as key informants? And do we have diverse leadership and workforce? It's wonderful to be interested in developing and implementing different public health programs in diverse communities, but the extra step would be to actually incorporate in the organizations themselves individuals with diverse backgrounds in leadership positions. So how do we approach our public health work with cultural competence? There are several practical ways to go about doing so. For one thing, in our conduct of community assessments, we do that all the time, community health assessments. One very important way to go about doing so would be to identify members from the community themselves to be our, quote, community consultants or key informants. For example, contacting local leaders. These are individuals with not only a wealth of knowledge about the community itself, oftentimes they're members of the community with shared cultural background, and in addition to that can provide very important entree to working with the community, as well as insights about how best to go about doing so. This would also lead us, hopefully, to identifying the best communication strategies to working with the community, and also ultimately the communication means that we'll determine is best for our public health programs or interventions. This suggests that we're using culturally competent practices, namely practices like community-based participatory research, or CBPR. Very integral to that paradigm or approach to doing public health work, as well as other kinds of work or research, is that every component of the process of the work we do involves collaboration with and consultation with members of the community or the target population. From the very outset, meaning or including even the definition of the public health problem, the definition of or the establishment of the priorities. We may, for example, go in, identify health disparities in a particular community and think that it's really important to address certain ones, but after engaging in community participatory work, we may find out that members of the community themselves think that a different health issue is much more important. And that's an important starting point to establishing what are the key or priority health issues with the community, and then going forward in a collaborative way to address them. One example of the kinds of research or development of interventions that integrate cultural values specifically might be the wide range of efforts that have taken place already in public health that have involved engagement with faith organizations or faith-based institutions. With that, using just that as one example, those are established institutions within communities that members have high regard for, engage with on a regular basis, and are receptive to messages that are discussed and promoted within these organizations. So partnering with those kinds of organizations, as well as similar organizations, would probably be a very effective way not only to implement health-related interventions, but also to do so in a culturally competent and sensitive way. Finally, it's likely that taking these steps will then better inform the development of the specific health messages that we ultimately do develop, and allow us to determine which is the best way in which to implement them. So it might be through convening focus groups that individuals who are more collective in their orientation might be more receptive to. On the other end of the spectrum, surveys, individual surveys, might be the best way to collect this information, because it might be more in line with individuals or groups that are more individualistic and communicate better that way. So those are just some examples in which our work as part of the public health workforce can start to be conducted in a more culturally competent manner. So just to be clear, since approaching our work in public health in a more culturally competent way pretty much goes hand in hand with working very directly with communities and community members, this paradigm, the CBPR, or community-based participatory research approach, is really an important and useful model to keep in mind as we try to work more culturally competent with groups. That said, I think it's important to state the definition and to think be very thoughtful about what that means in terms of our practice. It's a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. CBPR begins with a research topic of importance to the community, with the aim of combining knowledge and action for social change to improve community health and eliminate health disparities. I like that definition, and particularly in this presentation, because it pretty much brings us full circle. We started off at the point of describing the fact that, unfortunately, very significant disparities in health exist when you look at different cultural groups or different racial ethnic groups. And if we work hard and thoughtfully to increase our levels of competence in working with diverse cultural groups, then doing so with this community-based participatory research model not only makes it very clear that that involves and requires that we engage very closely with members of these groups that we're interested in influencing their health outcomes because disparities exist, but it also incorporates in the definition this commitment to social change. Public health is, I think, unique among many of the other health-related professions in that a commitment to improving social circumstances across the board, this social justice orientation, is very much part of the mission of the work we do in public health. And so this definition for community-based participatory research not only provides us with a model for working closely with members of other groups, in this case other cultural groups, to incorporate their involvement in the work we do, but it also says specifically that with one of the main goals is that it affect or improve the disparities that exist currently, and it might actually require that we do so not only through public health intervention, but through other actions that seek to improve the social circumstances of these groups, that social justice mission that is part of public health work. So to start wrapping up this presentation, one important question will be, how do we improve cultural competence in public health systems? We've gone from improving ourselves as individual public health professionals to the organizations that we may work within or together with, to the larger systems, municipal level health departments, state, national public health programs, organizations. there are various elements that we would want to think about in terms of improving cultural competence at this larger systems level. Work toward organizational cultural competence. That organizational assessment tool that I previously referred to would presumably help us do that. Try to assess in very key areas the level to which organizations have established explicitly goals in improving cultural competence, not only in the work that they do, but even in the makeup of the staff within the organization. Also, increase diversity within leadership and workforce. Additionally, adapting medical cultural competence models to use in public health. We've done some of that already. Part of this presentation has been informed by existing work that has been done in the medical field and somewhat in the nursing fields. And there's additional knowledge and materials, information out there that's more clinically oriented for the medical fields that we in public health can look to and adapt for our use on a larger population level. And then finally, policy development, the ability to try to advocate for and affect changes in policies or establishment of policies that explicitly recognize the importance of improving cultural competence. So this slide just provides a graphic representation of how cultural competence can be carried out to the ultimate outcome of having a favorable impact on health disparities. If you look at the center red circle, that depicts cultural competence among individual public health workers, people like yourself, myself, others who seek every day to try to work within larger systems in addressing public health problems. What we then hope to do in our work is develop programs, conduct research that will better inform the ways in which we can go about having an influence on the health of different groups. Our programs, interventions, the research that we do is situated within larger organizations, an academic institution, a public health department, a community-based organization, a social services organization, whatever that organization is. All of these organizations, institutions are going to be within larger systems, maybe within a municipal setting or a state setting. And we would hope that the combination of efforts undertaken from the individual public health professional to the larger public health systems will ultimately have an impact on a reduction of disparities in the kinds of care that are delivered, and finally a reduction in health disparities among individuals themselves or different groups. Like the groups that we saw in the earlier example around infant mortality and the disparate experiences that are experienced by members of different racial and ethnic groups. So achieving cultural competence in public health is definitely a work in progress. There are a few things, however, that I would summarize about the work that we see is important in becoming more culturally competent. First, we look at cultural competence as a way to improve or address the problem of health disparities across groups. Secondly, work continues, work is ongoing, if you will, in healthcare and in public health in terms of improving approaches to becoming more culturally competent. This is a field that is in development and that we see the possibilities for only getting better. Thirdly, we can become culturally competent public health providers clearly by developing or improving relevant knowledge and skills in the field, as well as being very thoughtful about our own attitudes, reflecting on our own attitudes vis-a-vis other groups, and learning more about the belief systems, practices, and behaviors of different groups as well. Fourth, we can apply cultural competence by always making an effort to consider culture in the interventions, programs, and research that we conduct. that we keep that factor, if you will, as a very important and key factor in any of the work we do. And finally, that public health systems would benefit from increased diversity and ongoing policy development. So in our professional capacity, that we make explicit efforts to interrogate and explore the level of diversity that may or may not exist in different public health organizations, as well as whether policies are explicitly in place around diversity within the organizations and their commitment to cultural competence.